Mhm. So, guys, very good evening to all of you. And I could not conduct the live session last time because I was busy with some commitments. But whenever I'll not be able to do it, I'll conduct it. Like once I'll combine two sessions. As today's session, I'll be combining last week. See, that's why I'm saying I'm combining G Pharma with ANS, autonomic nervous system, right? So पिछली बार जो नहीं किया हमने, right? So today I'll be covering both G Pharma, right, as well as ANS, autonomic nervous system. So I hope guys have studied the last 2 weeks, and today again I'll post the schedule for the next week, right? I'll post it. So guys, it's already 7 o'clock. Let us begin with the MCQs today. And these are new MCQs. They are not that similar to the previous sessions I've done. Some of them you might find similar, right? Most of them they are new MCQs. Schedule show कर दीजिए. Schedule I have already shared, guys. Right, I already shared on Instagram. YouTube also I do share. So anyway, so let's begin with today's question. First of all, आज के questions करते हैं. What are the questions for today? In G Pharma, which of the following statement is true regarding generic drugs approval? Generic drugs approval. New drug application is filed with CDSCO. New drug application is filed with FDA. Bioequivalence is equivalence of AUC. All of you know what is AUC. It is area under the curve, right? Himanshu Verma, Ram, good evening to all of you guys. Bioequivalence is equivalence of AUC and Tmax. So we have four options. And again, this is a new drug, right? You'll not find these MCQs, which I'm going to discuss. They're newer ones for simple reason. I have made these MCQs so that I can tickle your cortex. We can find new MCQs, right? So I posted schedule, guys, on YouTube, on Instagram, everywhere. All right, so look at the MCQs. Try to find the answer, right? So if you have gone through the topic nicely, you'll find the answer. Now, even if you don't find the answer, even if you're not confident about the answer, still do comment the answer, right? It doesn't matter. Let us go wrong here so that we do not go wrong in the exam. So यहाँ पर answer करना है, right? So whatever you think is the answer, take some time. Then you can let me know in the answer. Is which of the following statement is true regarding generic drugs approval? Right, option A, new drug application is filed with CDSCO, new drug application is filed with FDA. Bioequivalence is equivalence of AUC, bioequivalence is equivalence of AUC and Tmax. All right, so let the answers flow, guys. I'll give you guys some time to think over it. And everyone who is in the live session, you should participate, everyone, right? New application लखनऊ में है, नहीं ऐसा कुछ नहीं है, लखनऊ में नहीं है, right? So I'll tell you the answer, I'll tell you the explanation, I'll tell you which options are right and wrong and what is the reason behind that. Jitesh Jigar, Jai Jagannath, and good evening to all of you. But yes, come on, let the answers flow. All right, so I can see a lot of you guys have given right answer. Now see here, those who have given answer A, many of you have given answer A. Now why, see, an application is filed with CDSCO, right? Application is filed with CDSCO, that is correct. But that is for a new drug. That is for a new drug, not for a generic drug. All of you know a generic drug is not a new drug, right? So whenever it is a generic drugs approval, the application is called as ANDA. Whenever it is new drug, the application is called as NDA. So NDA is new drug approval filed with FDA or CDSCO. FDA in US, in India it is CDSCO. If it is generic drug, I call it as abbreviated new drug application. A for abbreviated new drug application, right? So here, NDA, new drug application is wrong. The reason being it's not a new drug, it's a generic drug. All right, it cannot be, it's not a new drug application, and that too, even it, FDA is wrong as far as NDA is concerned. Bioequivalence is equivalence of area under the curve. Now this is wrong. We've discussed this. Bioequivalence. So D is the answer, guys. Bioequivalence is when there is equivalence of AUC and Tmax. Right, AUC and Tmax. All right, so this is a topic based upon a PYQ. Now tell me, the PYQs are number one, AUC determines what and Tmax determines what, right? There are two things related to drug absorption. One is called as extent of absorption, one is called as rate of absorption. So what is AUC? What is AUC? AUC is extent or rate. What is AUC, guys? AUC is what? Rate or extent? What do you think? AUC or area on the curve, right? So these are your PYQs. I mean, these have been asked, but the clinical application of the topic, I should know about it. So as I've said, told you guys this, you can write RATE, and from this you can remember that rate of absorption, rate is Tmax, whereas extent of absorption is area under the curve. So this is a trick I've told you guys to remember how to quickly find the answer. Excellent, guys. Karan, Malini, Murali, all of you have given the right answer. Now, help is a different mnemonic, right? Here the mnemonic is rate. Help is for the area under the curve, right? For these, the DRC, to find the efficacy and potency, right? So rate is Tmax, area under the curve is extent, right? So I hope that is clear, guys. Now moving on to the next question. A patient being treated for colorectal cancer, right, develops diarrhea. After giving loperamide for diarrhea, he developed respiratory depression. All of the following drugs can precipitate this condition except. Right, so again, this is based upon a topic that is frequently asked in INICET. It is based upon that topic. So it's a PYT, it is not a PYQ, right? So first of all, here, yeah, I'll clear the doubts at last, guys. At last, you guys can ask me the doubts. I always used to do it. I mean, these weekly pharmacology sessions was something I started doing it during the COVID times, right? Because you guys were alone at home, I was alone at home, right? So we're kind of the pillars of support for each other, right? So I'll take your doubts at last. Don't worry, guys, right? So patient of colorectal cancer develops diarrhea after giving loperamide. The diarrhea he developed respiratory depression. All of the following drugs can precipitate this condition except. All right. So if you don't know the answer, just go for a wild guess. Sometimes, see, for all the 200 MCQs, you'll never know the right answer for each and every MCQ. For some, you have to make wild guesses, right? You'll have a gut feeling that, okay, this might be the answer. You might not know the reason why this is the answer, but you'll have that gut feeling, right? So except quinidine, verapamil, clarithromycin, mycophenolate mofetil. Mycophenolate mofetil. So what is the answer, guys? All right, excellent. So many of you have given the right answer, guys. See, except is important, guys. Except, right? So answer is mycophenolate mofetil. Now, first of all, let me ask you a few questions. Which drug do you think here am I talking about? Which anti-cancer drug? Which anti-cancer drug used in colorectal cancer can cause diarrhea? So let us solve this MCQ gradually, right? So this diarrhea is caused by which drug in cancer used for colorectal cancer? I'll give you the options. All of you know which are the drugs we use in colorectal cancer. 5-fluorouracil, oxaliplatin, then we have to use irinotecan, then we use folinic acid to prevent the toxicity or to increase the effect. So which one is the drug used in colorectal cancer out of all of these that has caused diarrhea here? Is it 5-fluorouracil? Is it oxaliplatin? Is it irinotecan? So I should know the topic, right? I should know the reason why this is the answer. I should know why this is the reason, this is the answer. Excellent, guys. So Murali Krishna has given the right answer. Murali Krishna, excellent. It is, guys, irinotecan. Irinotecan can cause diarrhea. It is called as delayed diarrhea, which can be seen. It's not 5-FU. Though 5-FU can cause mucositis. So irinotecan can cause diarrhea. If irinotecan causes diarrhea, for that, the drug of choice is loperamide. The drug of choice is loperamide. Now, normally, if I give loperamide, now many of you would know the answer, would have guessed the answer, but you might not know what is the reason. So suppose this is our blood-brain barrier. Suppose this is our blood-brain barrier. And whenever I give loperamide, it crosses blood-brain barrier, but it is not concentrated in the brain. The reason is there is a pump present And all of you know these are called as P-glycoprotein pump responsible for drug efflux. So the moment it crosses over, it is immediately thrown back into your systemic circulation from your brain. So in other words, why I have no central effects is because of drug efflux by PGP. So in other words, if you understand this, if I block PGP, I will block this efflux of drug, and that loperamide will persist in your brain, and then it can cause CNS toxicity like respiratory depression, which we are talking here about, right? So PGP, very good. So PGP is an important topic for INICET, guys. They have asked a lot of MCQs. So here, the MCQ that I'm asking is, it comes down to this point. All of the following are inhibitors of P-glycoprotein pump except. So quinidine is an inhibitor. Verapamil is an inhibitor. Clarithromycin is also an inhibitor. So what is not an inhibitor is mycophenolate mofetil. Now see, many times you might not know what is the answer, right? But you get the answer, right? By gut feeling. So here, if you did not know the cause, I mean, how you got the answer, then also it's okay. But at least from the explanation that I'm going to give, learn the cause, the reason, right? For example, they can ask you, this was seen because of which interaction? Enzyme inhibition, PGP inhibition. I give you two options. What would be the answer? A lot of people will go for enzyme inhibition as the answer. You might have thought, a lot of you guys might have thought that. But it is not enzyme inhibition per se. It is PGP inhibition, right? All right, ABC pump are PGP inhibitors. All right, very good, guys. So, moving on. Next question. Which is true about pharmacokinetics of digoxin? So, digoxin is a very complicated drug. They love to ask about this drug. It is given as loading doses because it is distributed into adipose tissues. Clarithromycin can cause digoxin failure. Plasma concentration of digoxin for TDM. TDM is therapeutic drug monitoring. They determined 7 days after starting the drug. Dialysis is not done for digoxin toxicity. All right. So which is the better answer here? A, B, C, or D? All right. So what is the answer, guys? Come on. Say if you look superficially, you might get derailed. Both A and D. Right. That is what I was saying. All right, guys. So most of you given the right answer. Answer is D. Answer is D. Dialysis is never done for digoxin toxicity. Now, then you would ask me, sir, but how? It is given as loading doses because it has high volume of distribution. But remember, it is not distributed into adipose tissue. Rather, it is distributed into skeletal muscles. They are not distributed in adipose tissue. Clarithromycin can cause digoxin failure. That's wrong. It causes digoxin toxicity. So these are all PYQs. Plasma concentration of digoxin for TDM is determined not after 7 days. See, why? Tell me why C is not the answer. See, it's not always about the right answer. It's always about the best possible answer. So here, C or D can be the right answer. C or D can be the right answer. Yes, Dr. UK. UK is United Kingdom or Uttarakhand. Anyways, wherever you are from, is it, if C is not the answer, as I've said, why C is not the answer? Because, see, when you do TDM, whenever I do TDM, what is the time period? Tell me. Whenever I do TDM. So, Astika Mishra, it depends upon T half. Very good. It depends on T half. That's the right answer. But TDM is to be done after how many high flaps? In other words, I'm asking you, it is done when you achieve something called as SSPC. What is SSPC? Steady state plasma concentration is achieved after how many half-lives? 4 to 5 half-lives. It is achieved after time taken for digitization. That is correct, right? 4 to 5 half-lives. And digoxin has a half-life of around 36 to 48 hours. 36 to 48 hours. That means it becomes 7 to 10 days. 7 to 10 days. So as I said, C can be a right answer as well, because I can do it on 7th day, 8th day, 9th day, 10th day, 11th day, because steady state would be achieved. But if I have to choose one answer between C and D, the better answer would be D, because see, if there is something which is plumb, like dialysis is never ever done for digoxin toxicity, that is the eternal truth, like God is there. There's eternal truth, right? Nothing above God. So you never do it. So 4 to 5 half-lives, excellent guys. So here C, D could be right. So I'll do the TDM after 7 to 10 days. Now from doctor to doctor, it might depend. All right, 4 to 5 lives. Yeah, we have to choose a better answer, and the better answer is D here. The better answer is D here. So that I said, C can be right, but in this context, in this MCQ, C would not be a better answer because D is a better answer as compared to C, right? So if all the 3 options were wrong, and suppose this option was dialysis is done for digoxin toxicity, then I would have gone for C as the answer. So you have to choose the best possible answer. It's not always about the right answer. DGFAB is used, that's correct, we use DGFAB. Now moving on, look at this. Dosing of drug depends upon particular pharmacokinetics parameters. Which of the following match is incorrect? Right, infusion rate, clearance, loading dose, volume of distribution, terminal half-life, volume of distribution, maintenance dose, plasma concentration. Look at this. So again, this is an MCQ that I have made from multiple PYQs. So I've combined multiple PYQs into one MCQ. And so that you'll be revising 3 to 4 MCQs in this one MCQ, right? So look at this carefully. Dosing of drugs depends upon particular pharmacokinetic parameters. Which of the following matches incorrect? Infusion rate depends upon clearance. Loading dose depends upon volume of distribution. Terminal half-life depends upon volume of distribution. Maintenance dose depends upon plasma concentration. Maintenance dose depends upon plasma concentration. All right. Let the answers flow. So many of you given C as the answer. Let us see. All right. Infusion, that means infusion rate depends upon clearance, right? All of you guys, if you have saying the answer is C, that is correct. Loading dose depends upon volume of distribution, that is correct. So these two things, these are correct. And you are saying, I'm not saying, you are saying, as of now, that's so this is the answer. This is the answer, right? This is the answer. Now, then maintenance dose depends upon plasma concentration. This is not what I'm saying. You are saying, not I'm, right? You are saying that maintenance dose depends on plasma concentration is true. Not according to me, according to you, right? So is this a correct statement or not? Maintenance dose depends upon plasma concentration. If maintenance dose depends upon plasma concentration, all right, so infusion rate is equal to plasma concentration into clearance. Maintenance dose is equal to plasma concentration into clearance into time. Are you getting my point here? Are you getting my point here? This plasma concentration is called as steady state plasma concentration, which is always constant. I have to keep this steady state plasma concentration within a constant range to produce adequate effect. So plasma concentration never decides it. So what decides here? Both is clearance. Both in clearance, right? So this, even this option that you've said yes is not yes, is rather no for this. Here the answer is maintenance dose depends upon plasma concentration is wrong. So you could have ruled out, and see, again, I'm giving you a message here that if you don't know about an option, if you don't know, for example, you don't know about terminal half-life and volume of distribution, don't pick it as an answer because you don't know. Pick an answer after ruling out whatever you know. Now, if you look back at what you know, is maintenance dose and infusion rate both depend upon clearance. So rule out whatever you know, right? Whatever is correct, you know. Then whatever is remaining, go for that as an answer. All right. So here, terminal half-life, it depends upon volume of distribution. That is, yes, this is correct. See, what is terminal half-life? See, one half-life is the time taken for a drug to be metabolized, but the concentration decreases by 50%, right? Now remember, that is the normal half-life of a drug. Like I need a time decrease the drug by 50% in plasma, whichever is present in plasma. But remember, whatever drug I have, whatever drug is present in your tissues distributed that is not currently undergoing metabolism, that would come back to plasma later and would undergo metabolism and be removed. If I consider that time, which is required for a drug to be removed from the body as a whole, I will call that as terminal half-life. So remember, the terminal half-life of drugs are usually longer as compared to the normal half-life, right? So for many drugs, like digoxin, amiodarone, even, do you guys know that what is the half-life of, how long acting is bedaquiline as a drug, the new anti-TB drug? How long acting is bedaquiline? How many hours or how many days? Do you remember? See, bedaquiline, delamanid, pretomanid, these are new drugs in TB. They're very important. So if you don't know, all right, if you don't know, then let me tell you the 165 days. So do you think that it takes 165 days for bedaquiline to be metabolized? Obviously, no. Right? The terminal half-life of bedaquiline is so long. That is because, if you remember, in pharmacokinetics, we've discussed about bedaquiline, that it is sequestered in our tissues. Bedaquiline actually gets deposited in our tissues. That is the reason why that is called as terminal half-life. Anyways, so that is what we learned today. See, solving MCQs is an art. You'll not know answer to all the MCQs, but you have to keep faith on what you know rather than running after things which you don't know. You got my point? All right, moving on. PT-INR is frequently monitored in patients owing to polymorphism in which gene? CYP2D6, VKOR, CYP2C9, both B and C. Both B and C. Right. So PT-INR. So all of you know why are we moving away? Why we have moved away from warfarin into sorry, I forgot the word here. Patients on warfarin. This is one word I forgot while making this MCQ, right? So PT-INR is frequently monitored in patients owing to polymorphism, patients on warfarin. So all of you know that on warfarin, we frequently need to monitor PT-INR. That is a cumbersome job. So we have moved on to DOAC, right? DOAC. So what is the answer, guys? A, B, C, or D? Right. So see, here you might go for the wrong answer if you don't know the topic completely, right? All right. Let the answers flow, guys. Let the answers flow. What do you think is the answer? All right. Now see, all of you have given answers. All of you have given answers, and your answer is a good answer. But every good answer is not a right answer. You have to understand this. And sometimes you have to go easy on yourself, even if the answer is wrong. Like, for example, let us say CYP2D6 can never be the answer because we have discussed about 2D6 is metabolizes mostly drugs of psychiatry. VKOR, yes. Vitamin K oxidoreductase gene. CYP2C9, yes. So those who have gone for the answer as B or C, your answer is wrong, right? But you should not be upset about it because your answer was good, right? Good answers. So wrong answers are good answers as well. So here, all of you know the answer. The answer would be both B and C. The answer, so D. So many of you have given the right answer as D. So what did you learn here? That why there is a variability in dosing of warfarin from one patient to another patient. That is because of polymorphism in two types of gene. One, a gene for the enzyme that metabolizes warfarin is CYP2C9. Second is a gene which is targeted by warfarin. Warfarin blocks VKOR. That gene can be polymorphic. So two reasons. VKOR. So warfarin variable effect is because of CYP2C9, an enzyme that metabolizes warfarin, or VKOR, an enzyme which is targeted by warfarin. So this is again an important MCQ, and it has been asked in a different way earlier. I've changed that PYQ in a different way. So as I said, we'll be discussing new type of MCQs here, right? Now moving on, a patient of Crigler-Najjar syndrome develops toxicity to irinotecan given to a patient at normal doses. The reason behind this interaction is inadequate metabolism, increased absorption, receptor upregulation, pharmacogenetics. All right, Shrevali, COP2C19 clopidogrel, that's correct. That's the right answer. So guys, what is the reason behind this interaction? The Crigler-Najjar syndrome, patient was given irinotecan, which is an anti-cancer drug. All of you know that, right? and we are developing toxicity here. So is it because of inadequate metabolism, increased absorption, receptor upregulation, pharmacogenetics? All right, you can take some time, you can think. I'll wait for your answers because I want you guys to commit to an answer. You might be wrong, and that's fine. We might go wrong. There is nothing wrong in it. But we should commit to an answer, even though we can go wrong. All right. So guys, as I can see, majority of you guys have given the right answer. The right answer is inadequate metabolism. Now see, all of you know what happens in Crigler-Najjar syndrome. There is a decreased or absent glucuronide transferase, right? So it is not pharmacogenetic condition, right? So it is decreased or absent glucuronide transferase, and glucuronide transferase metabolizes irinotecan. It metabolizes irinotecan. So deficiency or absence of glucuronide transferase will increase the risk of toxicity. So inadequate metabolism is the right answer. Other are incorrect options like increased absorption, receptor upregulation, pharmacogenetics. It is not a pharmacogenetic condition. Remember, right? I guess. Very good. Next question. Elimination constant of a drug is calculated from. So again, this is a PYT, not a PYQ, right? Elimination constant of a drug is calculated from half-life by clearance, clearance by volume of distribution by clearance, clearance by half-life. All right. So if you have solved PYQs, you should be able to solve this. Because I told you, now if you have just mugged up the PYQ, then not be able to solve this. If I understood that PYQ, this is an MCQ from your PYQ or a PYT, right? But not that exactly PYQ. Now, what was the PYQ? The PYQ was they had given you the elimination constant of a drug, and then they had asked, this was given. Then they had asked to calculate the half-life of the drug. It was a numerical. It was a numerical. And I have made that MCQ from that numerical, right? So you'll see in your exams, everything is related to PYTs. I mean, 90% of MCQs are from PYTs. All right. So I guess you guys would have solved that MCQ where this was asked. K elimination constant we discussed over there. All right. So all kind of answers we are having B, C, D, everything is there. All right. So let us see. What is the answer? Let us see. See, T half of a drug is equal to 0.693 into volume of distribution, right? This is one formula. Volume distribution by clearance. Volume distribution by clearance. Another formula for half-life is equal to 0.693 by elimination constant. Anyways, so if you guys would have gone wrong, it's okay. Nothing to worry about. At least learn now that what would be the formula, how do we calculate elimination constant? T half is equal to 0.693 into VD by clearance. T half is equal to 0.693 by elimination constant. So what is the answer? What is the answer is? At least now you can calculate the answer, right? So what's the answer, guys? Excellent. Now B is the answer. It's clearance by VD. Clearance by VD. So whenever you divide clearance by VD, you get the elimination constant. So again, go through that PYQ, that numerical. This was the numerical. This was the numerical is based upon this, and this is what I've converted into an MCQ. So see, this is how the MCQs are changed in a NEETPG or INICET. So you have to master the PYTs. Bicarbonate as an antidote can be used in toxicity of all of the following except. So where do I not use bicarbonate? Aspirin, amphetamine, amitriptyline, antipsychotics. All right. Aspirin, amphetamine, amitriptyline, antipsychotics. Yeah, maths question C. Unfortunately, Swastika, G Pharma is mathematics, basically, right? So a little bit of mathematics we need to understand in G Pharma, and that is not a difficult maths. I mean, it is class 5 maths. I'll see the mathematics of nowadays kids, I mean, your head will spin compared to whatever maths we used to have at least. All right. So bicarbonate can be used in toxicity of all of the following except aspirin, amphetamine, amitriptyline, antipsychotics. Come on guys, let the answers flow. Whatever you think is the answer, commit to one option. You might go right, you might go wrong, right? No issues. Even if you go wrong, we'll learn something, right? We'll learn something. All mine are basic drugs. All right, guys. So amphetamine, excellent, guys. Most of you given the right answer. Amphetamine is a basic drug. So I never use this thing against amphetamine. Bicarbonate is not used. Rather for amphetamine, what I use is ammonium chloride, the urine acidifying agent. So ammonium chloride is an urine acidifying agent. I use it because amphetamine is a basic drug. Is a basic drug, right? Is a basic drug. Now see, this is say amitriptyline. Now here, if I look at aspirin, very good, very good. Amitriptyline is a TCA. Now see, for this, I have discussed this question, and now for next session, in this session, intra session, it becomes a PYQ, right? And in CNS, whenever I'll come back to CNS, I'll again discuss this topic, but in a different way. So we'll see how the PYD changes, right? PYD changes. Yeah, amphetamine mechanism is displacement. All right, very good, guys. All right, which of the following statement is false? DRC. We cannot end G pharma without a dose response curve. A, B, C, D, you can see, guys, there is an image with 4 DRCs, A, B, C, D. A and B affinity is same, A and B efficacy is same, C and D efficacy is same, A has more potency than B. False. So which one is false, right? So answer, which one is false? So take some time, you'll need some time to realize what is the possible answer. And then you guys can comment, right? Let us see if you guys can get this right. If you don't know the answer, again I've said, if you don't know the answer, rule out what you know. Don't focus on what you don't know, right? Focus on what you know. Please never focus on what you don't know. So try to first of all rule out the options in your head based upon whatever you know. Don't focus on what you don't know, right? So whatever you know, believe in that, then rule out, you'll get the answer right. Excellent, guys. So most of you guys have given the answer right. The answer is option A. A and B affinity is same, right? So all of us know that A and B efficacy is same. This is true. So I can rule out. Even if I had no idea about option A, B I know it's a very simple MCQ. C and D efficacy are same. This is also true. They have similar height. I can see. A has more potency than B. That is also true. Now, some of you guys have marked D as answer. Guys, D will not be the answer. Because A and potency B is not same. Potency of A and B is not same, right? So first of all, let me come down to why this is answer. A and B affinity is same. Now, if I have to compare affinity of two drugs, then both these drugs, they must act upon same target. So only then I can compare affinity. See, for example, I can compare affinity of captopril to enalapril for ACE, but I can never compare affinity of captopril to nifedipine. The targets are different, right? So when do I know that the target is same or not in a DRC? For that, you have to look at how the DRC propagate. Are the DRC parallel or not? So the DRCs are parallel only if the DRC is parallel. So you can see here, I mean, the DRCs like A and B, C and D, they are not parallel. I cannot compare affinity. But if I look at A and C, the DRC is parallel. If I look at B and C, or B and D, the DRCs are parallel. So the DRCs, they have to be parallel so that I can compare, right? So help mnemonic, excellent, guys. Help mnemonic is HELP. All of you know what is HELP. HELP is height. From height, I can calculate efficacy. From left, I can calculate potency. Now, for those guys who thought option D is answer, for them, I'm saying this. How do you compare potency? You take a particular response. So on y-axis, there is a response. I take a particular response. I calculate what is the dose required for that particular response by a drug. For that, I have to draw perpendiculars on the DRC, then draw a perpendicular on the dose axis. Now, if you can see this clearly here, for the same response, the dose required for A is lesser than B. So A is more potent. A is more potent as compared to B. Got my point? So you don't have to look at the root. Even if the root is same, still the drugs would have different potency. Anyways, guys, so this is an evergreen topic where MCQs are asked. All right, which of the following parameters can be extrapolated from the graph given here? So I've given you a graph and I've asked you what can I possibly find out from this graph? Option A, efficacy, option B, affinity, option C, safety, and option D, potency. So what can I possibly find out from this graph? What do you think, guys? Efficacy, affinity, safety, potency. What is findable from this graph? So all of you know about this graph. I'm not, here it is. If you're not able to see, I'll write a little bit above this. On x-axis is logarithm of dose, as we always take, right? And here we have taken percentage of population. Here we have taken effect. And this is the marked parameter. This is the marked parameter. So first of all, what is the marked parameter? The marked parameter is what? Right, this is the dose. Marked parameter is the dose. It is a dose. It is a dose at which effect is seen in 50% of population. In other words, I call it as ED50. I call it as ED50. So ED50, in other words, this MCQ comes down to this. This MCQ comes down to this. ED50 is a marker of what? Yes, ED50 is a marker of potency. Excellent. So many of you guys have given the answer, right? Yeah, ED50, right? So the PYQ was like this. ED50 is a marker of what? I've changed that PYQ. In a different MCQ where I've given you the graph, you have to find out ED50 and then find out that ED50 is a marker of potency, right? ED50 is a marker of potency. Safety will not be the answer here. The reason being, why safety? Because therapeutic index is equal to TD50 by ED50 in humans or LD50 by ED50 in animals. Now, if this was the MCQ like TD50 by ED50, LD50 by ED50, then safety would have been answer, right? So ED50 per se is not a marker of safety. Why? Because what is ED50? ED50 is dose required to produce effect in 50% of population. So this effect in 50% of population is something which is constant. So effect is constant, it is not changing. What is changing is what? Dose required. More dose required to produce effect in 50% of population. Less potency, less dose required, more potency. So ED50 is a marker of drug potency. So again, this is not a difficult one. Which of the following is not a GQ subtype of receptor? Now, if you look at this MCQ, you might think that, okay, I have to mug up a lot to solve such kind of MCQs, but not. You don't have to mug up. If you know the basics of GPCR, if you know the basics of a topic called as GPCR that I've told you guys, you can find the answer even if you don't know anything. If you have a basic knowledge of physiology, from physiology you can extrapolate the type of GPCR. So the question is, which of the following is not a GQ subtype of GPCR? Oxytocin, angiotensin, alpha-1, beta-2, right? So think, what is the answer here? And then I'll tell you how to find out the answer even if you have no idea. Even if you have no idea what you're talking about, right? All right, guys, come on. So let the answers flow. What is the answer? What do you think? A, B, C, or D? So everyone has got to answer. You guys have to commit to one answer, even if it might go wrong. Which of the following is not a GQ subtype of receptor? So someone has answered oxytocin. So Avik Das has answered oxytocin. Now that is a PYQ. And that PYQ was, which of the following is a GQ subtype, right? And there your answer was oxytocin. What I'm asking is not. That is the reason why I say to you guys that PYQs can be misleading, right? So first of all, GQ subtype, whenever I talk about GQ subtype, they increase calcium. And what do they cause? They cause smooth muscle contraction. So guys, whenever whenever I talk about a GQ subtype of receptor, it increases calcium, and calcium causes smooth muscle contraction. Okay, let me not know which receptor is which subtype, GQGS, but I would at least know from physiology what is the function of a receptor, function. And if that function is smooth muscle contraction, it has to be GQ subtype. I've given you the clue, right? So oxytocin, what is the cause? Let me see. Uterine contraction, right? Smooth muscle contraction. Angiotensin, let us see. What does angiotensin cause? Vasoconstriction, smooth muscle contraction. What does alpha-1 cause? Vasoconstriction, prostatic urethra contraction, bladder sphincter contraction, again, smooth muscle contraction. Whereas what does beta-2 cause? Vasodilation, bronchodilation, uterine relaxation. So what is the answer, guys, here? The answer is beta-2. So I've told you this in my lectures as well. Even if you have no idea, what a receptor subtype is, you can make a guess from the physiological functions, because see, there is no limit to how much you can mug up, but there is no limit to how much you can understand. I've told this time and again. So excellent, guys. Many of you guys have given the right answer. Look at the MCQ. The antagonism, yeah, you have to rule out. A lot of times, see, all of you know, you have been giving GTs, right? Do you know the right answer to each and every MCQ? No, right? You have to rule out. Sometimes you can rule out 1, sometimes 2, sometimes 3, sometimes 4 when you don't know what is the answer, right? So the antagonism represented in the graph is not seen with, right? So there is a drug, you can see the antagonism, there is a drug. And then there is the same drug which is combined with antagonism, there is a change in DRC's position, as you can see here, right? And this is not seen. So always try to focus on what the MCQ is asking, is seen or not seen, right? Vonoprazan, omeprazole, aspirin, methotrexate. All right. Okay, let me tell you something. So why I made one mistake while making this MCQ. This MCQ has 2 answers, right? So now you have to answer two answers. So let us say this is a type of multiple true false question of INICET, right? So let us say, so it has 2 answers. This MCQ has 2 answers, right? A, B, C, D. So you have to give 2 answers. Right, not C. So first of all, so it has 2 answers. There is one thing I've cleared, that I made something wrong while making this MCQ. But anyway, so let us treat it as a multiple true false question. And what are the 2 possible answers? First of all, tell me something. This antagonism that we're discussing here, what type of antagonism is it? Competitive reversible, non-competitive, or competitive irreversible? What is it? See, guys, it's a case of competitive reversible antagonism. So competitive reversible antagonism is where there is a right shift in the DRC. All of us know that, right? In other words, I'm asking you here, which antagonism is not reversible? The MCQ not seen. The MCQ which is not seen. So which is not a competitive reversible antagonist, right? Not. Which is not. MCQ is not. So as I told you, always look at what is being asked. So what is the answer? 2 options has to be the answer. And you can rule out and find the answer here. Vonoprazan, omeprazole, aspirin, methotrexate. All right, so what do you think? So I've told you there are 2 answers here, 2 answers, right? There are 2 answers here, A, B, C, D. So many of you guys have given the answer before this as A and D, and A and D are exactly what is not the answer. The answer here is omeprazole and aspirin, because these are irreversible. So as I said, guys, this MCQ has 2 answers. That is my mistake while making this MCQ. So B and C. Vonoprazan, remember, vonoprazan, it is a PCAB, potassium competitive acid blocker. It's like PPIs, but it is reversible. Methotrexate is a reversible inhibitor of DHFR. That is the reason why whenever there is methotrexate toxicity, I try to negate it by giving folic acid. So anyways, you got the hint of it, what I wanted to ask here in this MCQ, right? All right, guys, moving on. Which of the following is not a constant in a drug following first order kinetics? So zero and first order, all of you know, it's a bread and butter topic in G Pharma. They love to ask, at least in one exam, either INICET, NEETPG, FMGE, some exam will have one MCQ from first order kinetics, right? Swastika Mishra, yeah, opposite answer. What I thought that happens because at times what happens in MCQs, you tend to forget at what is seen or not seen, except these things we miss, right? So which of the following is not constant in a drug following first order kinetics? Murli Krishna, very good. PCAB. Vonoprazan is a PCAB, potassium competitive acid blocker. All right, so which of the following is not constant in a drug following first order kinetics? Not constant in a drug following first order kinetics. Proportion of drug eliminated per hour, clearance, T half, plasma concentration. Again, it's not a difficult MCQ, it's an easy one. Because some MCQs will find easy in your exams, right? So I've tried to make a mix of easy and difficult ones. So even if you don't know the answer, okay, all right. All right, let the answers flow, guys. This is an easy MCQ. You should be able to solve such MCQs even in your dreams, and that too within seconds, right? So that you can save time. All right, all of you know. So what is constant in first order kinetics? How have I told you guys to remember this? Is in first order, the first segment of nephron is constant. First segment of nephron is PCD. Now C is clearance, T is T half. Now where some of you guys have got confused is what does P stand for? Now remember, P is not plasma concentration. P is not. P is rather proportion of drug. For example, I say 20% per hour. So 20% of whatever drug is present in my plasma of that is being removed. So P is not plasma concentration, right? So first order plasma concentration is not constant. See, plasma concentration, all of you remember, it is never constant, never constant. Not in zero, not in first order. Because essentially whenever I say plasma concentration is constant, it means I give a tablet of 100 milligrams, I give a tablet of 200 milligrams, the plasma concentration would be same. Is it possible? Think. It is not possible, never. Not in zero order, not in first order. So let me ask you, if I increase the dose by 2 times, dose was increased by 2 times and plasma concentration increased by 5 times. Which order is this? Right, I'm just asking you a follow-up question on this topic. So this is an MCQ they can ask ever, right? They can ask anytime. So there is a drug for which the dose is increased by 2 times and the plasma concentration increases by 5 times. So if you apply a little bit of knowledge, right, you can find the answer. Dose I increased by 2 times, plasma concentration increased by 5 times. Which order is it? Is it 0 or is it first? Which order is it? Excellent, guys. So most of you have started giving the right answer. It is 0 order. So a disproportionate increase in plasma concentration, that is the reason why drugs following 0 order kinetics, there is a high risk of toxicity. Whereas if I increase the dose by 2 times, plasma concentration also increases by 2 times, that is first order. Excellent. Now coming to the last MCQ for G Pharma. After this, we'll discuss ANS. Which of the following phase aim is same as that of pharmacovigilance? Again, this is a new MCQ. It has never been asked. It has never been asked. There are different MCQs which have been asked, but nothing as such. So, can you find the answer? All right. So, which of the following phase aim is same as that of pharmacovigilance? So, you have a lot of MCQs on pharmacovigilance, right? Very good. In Jamul, 0 order toxicity risk is more. Very good, right? All right. So, which of the following phase? So, even if you don't know the answer, you analyze, you think. Which phase of clinical trial the aim is similar to pharmacovigilance? Phase 1, 2, 3, 4. Right, what is the answer? Come on, guys. Come to one answer. What is the possible answer? Which of the following phase aim is same that of pharmacovigilance? The aim is similar to that of pharmacovigilance. Phase 1, phase 2, phase 3, phase 4. So, why we do phase 4? Why? So, answer is phase 4. Very good, guys. Many of you given the right answer. Why the answer is not phase 3, it is phase 4? Because we find out rare and long-term ADR in phase 4. Rare and long-term ADR, all of you know that, right? And pharmacovigilance is, again, it is done why? It is done, the aim is, as we know, it is to find out drug safety. And what is the meaning of finding out drug safety? Again, in pharmacovigilance, I again try to find out the same thing. If there is some rare or long-term ADR by a patient, then what I do? I ban the drug. So it's basically, what is pharmacovigilance? See, pharmacovigilance is a topic you should have studied in G Pharma. Pharmacovigilance is something that is, I keep an eye on the drug done by all the governments around the world to find out the same side effects. For example, suppose there is a drug which causes the rare side effect like MI, rafecoxib, and a rare side effect we cannot find in clinical trials. So the company which makes the drug has to conduct phase 4 trials. So government also conducts something like phase 4. It is not phase 4, it is called as pharmacovigilance. But the product is the aim of the end game of both these are same, right? Right, so maintenance dose is calculated based upon plasma concentration. How? See, maintenance dose is equal to plasma concentration into clearance, right? And that plasma concentration is steady state plasma concentration. And this steady state plasma concentration for a particular drug is constant. It never changes. I mean, that is where we see the effect, right? So the maintenance dose or infusion rate depends upon what is the clearance of the drug. More clearance, more would be the maintenance dose, right? Very good. No specific time in phase 4. Yeah, it's like surveillance, something like surveillance. This is one MCQ they can ask you. So guys, I've discussed all the MCQs of G Pharma. Let us come down to ANS, autonomic nervous system. MCQ number 1, ventilatory support is required in all of the following except myasthenic crisis, botulism, gentamicin toxicity, scorpion bite, right? So myasthenic crisis, botulism, gentamicin toxicity, scorpion bite. Now this is, you might be thinking, sir, how does it come under ANS? I'll explain. How does this MCQ come under ANS? Where is ventilatory support not required? Myasthenic crisis, botulism, gentamicin toxicity, scorpion bite, right? Now, if you don't know the answer, never heard about it, go for an option that you think is the answer, because I told you time and again. Even if you don't know the answer, you'll have a gut feeling that this might be the answer. I don't know the reason, but this might be the answer, right? So we have to, mark such answers as well. So even if you don't know, try to answer. Your logic might be as weird as possible. Like Shrevali's logic is D causes priapism, right? So it causes priapism. Gentamicin, no effect on respiration, right? So again, that is the logic. So you should have some logic. Right? Try to understand this. Myasthenic crisis. So all of you know that. So from your answer, I have deducted this. All of you know that in myasthenic crisis, there can be a decreased muscle contraction, respiratory paralysis can be seen. Botulism, again, if you guys are answering botulism, I don't know why you're answering botulism, because in botulism, there is a decreased release of acetylcholine, and that can cause respiratory paralysis because ACH is important for stimulation of NM receptor. NM. So decreased ACH means decreased stimulation of NM receptor, right? So myasthenic crisis can cause, botulism can cause. Gentamicin toxicity. Now see, gentamicin, it inhibits the presynaptic voltage-gated calcium channels, and that also decreases release of acetylcholine. So yes, even gentamicin toxicity. So imagine how they can ask you about gentamicin toxicity. A patient on gentamicin of pseudomonas infection is being given piperacillin and gentamicin, admitted in the ward, and all of a sudden the patient complains of breathing difficulty. What is the reason? The reason would be gentamicin toxicity. Gentamicin toxicity can also decrease acetylcholine and can cause that. So answer is scorpion bite. So I told you, always try to find the odd one out. So see, as someone said, that priapism is caused by scorpion bite, might be that is the reason. How weird your thought process does not matter. Nobody's going to ask you why you got the answer right. Anyway, scorpion bite is the answer here, because scorpion bite, the symptoms would be because of the toxin activates both sympathetic and parasympathetic. It's a very simple logic, guys. Don't mug up all the symptoms. Just mug up that it activates sympathetic and parasympathetic. So whenever I activate sympathetic, what is going to happen in ANS? Heart rate would go up, blood pressure would go up, even there would be pulmonary edema. Parasympathetic means what? All those parasympathomimetic symptoms, more salivation, more urination, plus priapism. Priapism or erection is because of parasympathetic nervous system, right? So prazosin. Mr. Nerd, thank you very much, guys. All right. So anyways, scorpion bite is the right answer. Now moving on. Which of the following match is correct about sweating and it is block? It's a very simple MCQ. It's a very simple MCQ. And I hope you guys are going to solve this. Which of the following match is correct? Which of the following match is correct about sweating and its block? Which match is correct about sweating and its block? Sympathetic, sympatholytic, sympathetic, parasympatholytic, parasympathetic, sympatholytic, parasympathetic, parasympatholytic. So which system and which class of drug? So here I have the system. Which system will cause sweating and which class of drug will block their sweating? This is what it means, this MCQ. This is the meaning of this MCQ, right? Sympathetic, sympatholytic, sympathetic, parasympatholytic. Now, one thing all of you know, that sweating is mediated by which nervous system? Sympathetic or parasympathetic? All right. I can see many of you guys are giving the right answer, but a lot of you guys have given the wrong answer for a simple logic, which there might be some lag, guys, from time to time. It might depend upon either your internet connection or mine, right? All right. So if you guys don't know what is the answer, just look at this. Suppose sweating, sympathetic nervous system activation. So this is your sympathetic fiber. And fiber is sympathetic, but the neurotransmitter is acetylcholine. Neurotransmitter is acetylcholine. And whenever acetylcholine is released, it will cause sweating because of overactivity of sympathetic nervous system. So what will cause sweating is not your craniosacral segments, it is your thoracolumbar segment. Thoracolumbar segment is what is going to cause sweating. But the released neurotransmitter is not norepinephrine. So the receptor here, which will cause sweating, is M3 and it is not alpha beta. So sweating is something. So this acetylcholine binding to M3 is what results in sweating. So I can say sweating is caused by overactivity of SNS or sympathetic nervous system. But do you think, can sympatholytics block sweating? No. I can block sweating by blocking M3 by drugs like atropine or a toxin like datura. So whenever there is atropine poisoning or datura poisoning, these are parasympatholytics. They can block sweating, and whenever I block sweating, the temperature goes up and there is hyperthermia. There are two POIQs on atropine and datura, but the patient has hyperthermia, and hyperthermia is where you make a diagnosis that this is a case of either atropine toxicity or datura poisoning, right? So what is the answer, guys? Now the answer is plumb, it is clear. The answer is B, sympathetic, and it is blocked by parasympathetic. It's very simple, guys. So I told you the MCQ is not difficult. All right, look at this 55-year-old male presented with flashes and floaters in both eyes. He was started with pilocarpine for treatment of presbyopia before 5 days. Which of the following condition the patient has developed? Vitreous detachment, vitreous hemorrhage, uveitis, retinal detachment. Right. So if you look at the symptoms, flashes and floaters, they can be seen with all these conditions. First of all, let me tell you, the ABCD, the options that are made here are such that these flashes and floaters, it can be seen with all. So you cannot make a differential diagnosis here based upon the symptoms. What will give you the answer is the use of drug pilocarpine. So you have to add pilocarpine to flashes and floaters and then find out what could be the possible side effect. Now, even if you don't know the answer, you should be able to mark it, because if you remember, I've told you guys, side effects of pilocarpine. Pilo is pilo. In Hindi, pilo is drink. And to drink To P low, you have to go to a bar. So B for broache, A for accommodation spasm, R for what? R for retinal detachment. We've discussed that, retinal detachment. So even if you don't know the answer is retinal detachment. Now see, in the years, the MCQs were like this. Which of the following is a side effect of pilocarpine? And you'll find the answer is retinal detachment. But now they'll give you a clinical case. Because the patient will not come to you and say, doctor, I have developed retinal detachment, right? He'll give you the symptoms. And based upon symptoms, you have to make a diagnosis. All right. So guys, you might go right, you might go wrong, and we are not here to judge each other, right? So let us go wrong here so that we must go right in the exam, right? Now moving on. Neostigmine is used in all of the following except, right? So neostigmine is a frequently asked drug: urge incontinence, NDMR reversal, cobra bite, gastroparesis. Neostigmine. So all of you know neostigmine is an ACHE blocker. Neostigmine is a blocker of ACHE. It increases acetylcholine. So it's basically a B for broache, bar, B for BROW, broache. Broache is headache in the area of the bro. That is called as broache. All right. So urge incontinence, NDMR reversal, cobra bite, gastroparesis. Now, see, I've told you time and again, please don't hurry with the MCQs. Always look at the except, seen, not seen. These will change the answer. All right. So neostigmine is used in all of the following except. So what is the answer here? Neostigmine is used in all of the following except. Excellent, guys. There is a flood of option A. So all of you cannot be wrong, right? So A is urge incontinence. All right, so tell me, if urge incontinence is not the use, then which incontinence is the use? In which incontinence I use neostigmine? So you should know the answer. You know the answer, that is very good. Then you also must know why A is the answer, right? You must know why urge incontinence is not the answer. Something must be the answer, right? Some other incontinence is the answer here. Which one is it? Sujit P. Kulkarni has given the right answer. Sujit, excellent. The incontinence, guys, is overflow incontinence, which is due to bladder atony. It is due to bladder atony. And what is bladder atony? Where the bladder is not contracting. Where the bladder is not contracting is bladder atony, and that is where I want to increase contraction of bladder by increasing acetylcholine. I'm using it. So NDMR reversal, cobra bite, gastroparesis, again GIT is not contracting, I can use this. So remember, NDMR reversal, cobra bite, I use it. Cobra, all of you know, is known as Nag. So two MCQs which are frequently asked. If I cannot remember everything, at least remember these two things. N for neostigmine is preferred. In N for NDMR reversal, N for Nag bite. Nag sap is a snake, is also known as, cobra is also known as Nag, right? So these two are very important. So neostigmine is used for Nag bite, NDMR reversal. Third, I use neostigmine wherever bladder and GIT is not contracting or not adequately contracting, I must say. So whenever bladder and GIT is not adequately contracting, like bladder atony, or let us say post-operative urine retention, or gastroparesis, or paralytic ileus, these are the conditions where I can use neostigmine, right? Karthik, the video would be available even after the live session. I never delete these videos because I know a lot of students might have classes or some other commitments. You might not be able to join me live. So there are people who watch after this. Which of the following drugs blocks only anionic site? Organophosphates, carbamates, acetylcholine, edrophonium. Right. Which of the following drugs block only anionic site? Which drug blocks only anionic site? Organophosphates, carbamates, acetylcholine, edrophonium. Only anionic. So see, nowadays the MCQs, they've started asking on which site on ACHE. Now if you remember, we have discussed about the structure of ACHE. If you remember, this is how the ACHE looks like, right? And in ACHE we have an acidic site, we have an anionic site, right? I'm asking which of the following drug it blocks only anionic site. right? Excellent, guys. So here, see, organophosphates, if I look at organophosphates, they block only astatic. If I look at oximes and adrophonium, they bind to only anionic site. If I look at carbamates, they block both acidic and anionic site. So here, only anionic site, only anionic, guys, only anionic. Your better answer would be adrophonium. Now, acetylcholine per se does not block any of these sites. Rather, it is metabolized by these sites, and whenever acetylcholine comes, acetylcholine, it binds to the anionic site and it is metabolized by the acidic site. So I cannot say acetylcholine is a blocker per se. It is not a blocker. It is a substrate for our enzyme. Whereas organophosphates, carbamates, these are all substrates. They are blockers. Like oximes also bind to anionic site, right? So guys, here the answer is adrophonium. What is a PYQ? They asked you which site is blocked by organophosphates, and in that case, your answer was acidic site, right? Excellent, guys. So most of you have given the right answer here. All right, what is the maximum dose of atropine used for treatment of bradycardia? What is the maximum dose? 3 milligram IV, 3 milligram subcutaneous, 3 milligram oral, 3 milligram rectal. So what is the dose I use? What is the dose I use? Maximum dose. What is the maximum dose of atropine used for treatment of bradycardia? What is the maximum dose of atropine used for treatment of bradycardia? 3 milligrams IV, 3 milligrams subcutaneous, 3 milligrams oral, 3 milligrams rectal. So what is the answer, guys? Now see, bradycardia is a medical emergency. It's an important topic, and all of you know that 3 milligrams is the answer. And see, sometimes the MCQs are easier one like this one. 3 milligram everywhere it is 3 milligram, right? The only route I have to choose is because it is an emergency, I have to go for IV route. So most drugs in emergency I use IV, except epinephrine, where I prefer it by intramuscular because of high risk of arrhythmia, right? Very good. 1 milligram, no response, repeat after 2 times. All right, guys, moving on. Which of the following drugs should be used to begin treatment of urge incontinence? Urge incontinence. Mirabegron, trospium, darifenacin, oxybutynin. All right, so look at this MCQ. To begin the treatment, so patient comes to me and I have multiple options for treatment of urge incontinence, right? Urge incontinence. So video is stuck. It might be something with let me see, guys. Let me see. Video is stuck. What could be the reason? Just give me 1 second, guys. What is the problem with? Okay, so sorry for the inconvenience, and there are some issues with the camera. All right, let's come back. Okay, so what is the answer? So I can see here, most of you guys have given the right answer. So here the answer is mera background. So whenever there is an urge incontinence, how do I use drugs, right? How do I use drugs in urge incontinence? Number one, in patients of urge incontinence, the first drug I always use is mirabagrone. Mirabagrone is the current drug of choice. Now let us say the patient says that he does not have money to buy mirabagrone, right? It's costlier. Then I'll go for anticholinergics, second line. And the anticholinergics that I preferred, these drugs you can remember as STD, standard drugs, STD, not that STD, right? So solifenacin, trospium, and darifenacin. These are the three drugs I prefer. And then at last, if the patient says he cannot afford even these drugs, then I go for other anticholinergics. Now see, whenever I use anticholinergics, either the second or third, the problem is dementia. The problem is dementia. And why dementia is a problem, and why I'm worried about dementia, because urge incontinence, it is a disease of old patients, elderly people. And you guys must have heard about something called as senile dementia. That is the reason why anticholinergics should always be my second choice. My first preferred choice should be mirabagrone. If the patient does not respond to mirabagrone, my second choice would be anticholinergics, which are STD drugs. If the patient still does not respond, then at last I'll go for the remaining one, like oxybutynin and all other drugs, right? So you have given the answer right, guys. Which of the following graph of heart rate belongs to dobutamine? Right. So look at this A, B, C, D, four graphs. These are the graphs of heart rate, graphs of heart rate. And up until now, they've asked MCQs on different drugs like epinephrine, norepinephrine, isoprenolone. I have asked an MCQ on altogether different drugs that they've asked from, that is dobutamine. Right. So we have four graphs here, A, B, C, D. And see, darifenacin, one touch given is, please change it. That is, I forgot to change the DOC for this. If something doesn't match to the theory, just change it, right? So which one is it, guys? Dobutamine, A, B, C, or D. So what is the graph for dobutamine? A, B, C, or D? What is the graph for dobutamine? A, B, C, or D? A. All right. Now, normally what happens is, if you look at this, whenever I use catecholamines, all of them, they increase contraction, but the change in heart rate is variable. Now, whatever the T issue always is about, this first graph you can see here is that of isoprenolone, which increases heart rate. Epinephrine also increases, but iso more than epinephrine. And norepinephrine decreases heart rate, right? Decreases. So it increases significantly, increases less so, decreases. Here it is normal. In other words, I'm asking which catecholamine maintains a normal heart rate, and that is dobutamine. Right. Now look at this. What is the answer here? The answer here. So A is increasing, C is decreasing, D is decreasing. This cannot be the answer. So here the better answer is which one? Option B. So B is the drug that maintains a normal heart rate. So your heart rate increases, here decreases, here decreases, here it is normal. So if they ask an MCQ on dobutamine, right, stick to normal heart rate. So dobutamine increases the force of contraction of the heart, but it maintains a normal heart rate. So force of contraction is gonna increase, but the heart rate will remain normal, right? That is the reason why I prefer dobutamine in acute CHF, because I don't want to increase heart rate, because the oxygen supply is already low. I would never try to increase the oxygen demand by increasing heart rate. Right, guys? Now, epinephrine is not preferred by which route in shock? IV, IM, subcutaneous, both IV and IM. Epinephrine is not preferred by which route in shock? IV, IM. Yeah, SK. Dobutamine acts upon beta 1, but dobutamine acts upon beta 1 of myocardium, not SA node. Right? Not SA node. So C and D, you can put any drug you want. C and D here, I've just drawn like that. It can be norepinephrine, it can be beta blocker, anything it can be there, right? So epinephrine is not preferred by which route in shock? All right, tell me guys, what is the answer? Shock, which route will I not prefer? IV, IM, subcutaneous, IV and IM. I thought all we gonna answer this MCQ is right. I thought it would be an easy peasy MCQ for you guys. Excellent guys. So some of you have given the answer right. See, answer is subcutaneous. Subcutaneous. Why subcutaneous is the answer? Because whenever there is a patient of shock, like anaphylactic shock, skin is not a priority organ for the body for supply of blood. It is centralized to the organs like your liver, kidney, blood, brain. So the blood supply to skin is the least of my priorities. And because there is no blood supply to the skin or very less blood supply to the skin in shock, by subcutaneous route, a drug will not be absorbed, right? So all of you know that we prefer IM. But if there is no response to IM, at last, when Yamraj is standing on the door, right, to drive Yamraj away, I will give IV, right? I will give IV. Oh my God. So what has happened to the camera? Just a second, guys. Okay, so it's actually, I have got a new camera, and that is why I'm having some troubles, because this is my first session with that new camera, right? So I'm still trying to understand. All right. Anyways, now, so if I'm giving it by IM route, and if there is no response, then I can give it by. All right, guys. So this is my the new camera, and I'm still trying to learn about it. I'm not very good with cameras and all. Whatever I try to learn about cameras and all is just for you guys, so that I can do these sessions and all. The older camera I had, it became pregnant. I'll ask me, sir, how did the camera become pregnant? Uh, Whenever you use a camera for too long with the batteries swell. So the batteries swell, and the battery is now stuck in the camera. I cannot get it out, right? So I can see the camera has become pregnant. So I bought a new camera, and mic is fine, I think. So you want me to buy a new, because see, you might have to increase the volume. So why is dobutamine used in stress test? Because the dobutamine would increase heart contraction at least, right? Heart contraction, and that is why. So anyways, if the camera goes off again, do let me know. I'll change it. So we have very few MCQs left. I want to wrap it up before the camera shuts up again. 25 A 25-year-old male presented with emergency with low BP and bradycardia after RTA. Which of the following drugs should be immediately started for stabilization of the patient? Right, immediately. So low BP and bradycardia after RTA, low BP, low blood pressure, and bradycardia after RTA. low BP, low blood pressure and bradycardia after RTA. Excellent, guys. You guys have stumped me. I am pleasurably surprised that you have given the right answer, norepinephrine plus atropine. I did change the MCQ from the previous sessions, but you still caught me. So it's a case of neurogenic shock. And in neurogenic shock, the BP goes low, but the heart rate also goes low. And in that case, what we do is the drug of choice for neurogenic shock is norepinephrine. But here, norepinephrine alone should not be given because norepinephrine itself causes bradycardia or decreases heart rate. So I'll be giving norepinephrine plus atropine. Excellent, guys. I'm proud of all of you. A patient complained of vertigo and was started on Vortine by a chemist, however, did not respond and went to doctor who asked him to explain vertigo, to which he said he develops dizziness for a while getting up from sitting position. Which of the following lifestyle modifications should not be advised to the patient? All right, look at this. Increase salt intake, use stockings, avoid small meals, avoid alcohol. Now let us see, it's a difficult one. Difficult in the sense you might not have read about it, but you'll learn something new apart from drugs today. Because it is a condition that is very commonly seen in the population and it is often misdiagnosed and misprescribed as well. Right. Now, please don't misread the question. Should not. Don't forget. I'm not asking which of the following should be advised. I'm asking which of the following should not be advised. Should not. Should not. Right. So first of all, what is the diagnosis, guys? Postural hypertension. Very good. Anshita Jain has given the right answer. It's a case of postural hypertension. Is a case of postural hypertension. Now see, excellent, guys. Many of you guys have given the right answer. It's a case of postural hypertension. The answer is avoid small meals. Rather, we ask the patient to avoid large meals. Now, why would you avoid large meals? What is the reason? Can you tell me the reason? We ask the patient to avoid large meals. We rather ask the patient to take small meals intermittently, right? A lot of times. Why would you avoid large meals? Anyone? Why would you avoid large meals? The reason being, whenever you consume large meals, a lot of your blood is redirected towards your enteric circulation, and that is something called as postprandial hypotension. Now think about the condition when you have a heavy carbohydrate lunch. You had a biryani, Hyderabadi biryani, which is impossible for a non-Telugu person to eat that one portion of Hyderabadi biryani. For example, I can never finish one portion. So you had that heavy biryani once, or if you have been to Odisha or West Bengal or some South states, we eat water rice that is called as Pokhala Bhato or Panta Bhato or some other names in South India. And what do you feel? You feel drowsy. That is because of postprandial hypotension, right? Postprandial hypotension. So the large meals, they worsen the condition. Large meal, they worsen the condition. So apart from this, everything is advised. Increase salt intake, use stockings. You ask the patient to avoid large meals, avoid alcohol because alcohol itself is a vasodilator. So here, the drug of choice is midodrine. This is the MCQ they have asked. But apart from that, you should know about it as well. So answer correct, explanation wrong, it is okay. It is okay. Many times you'll not know why the answer is right. Right? I guess. Which of the following drug can block hypokalemia caused by salbutamol? Which of the following drug? Sir, salt intake will also cause further increase in systolic blood pressure, hence widen the gap. Anshita Jain, postural hypotension. See, there are two ways of treating postural hypotension. Either you can contract the veins or you can increase the blood volume, right? For example, midodrine is a vasoconstrictor, that is a drug of choice. Or I can give fludrocortisone. It is also a drug, fludrocortisone, that increases more plasma volume. So whenever plasma volume increases, the risk of postural hypotension. See, what is postural hypotension? You have to understand. is when the blood is pulled back. Drug of choice is midodrine, guys. So again, the video is gone. Okay, okay, give me 1 second. Or should we do it without the video? All right. So, anyways, the video is gonna come. Don't worry about that. So already. So guys, which of the following drug can block hypokalemia caused by salbutamol? Hypokalemia caused by salbutamol. Which of the following drugs can block hypokalemia caused by salbutamol? Isoprenaline, digoxin, mirabegron, potassium chloride. Right. Tell me guys. All right. So if you don't know the answer, let me tell you here. See, first of all, the reason why there is salbutamol causes hypokalemia, salbutamol, what it does is it stimulates beta 2 receptor. All right, beta 2 receptor. So guys, if you know the answer, do comment. I'll tell you the answer. Reason, right? That increases cyclic AMP, and that cyclic AMP activates a pump called as sodium potassium ADPase. This is one of the reasons why there is hypokalemia with salbutamol. Now, if you want to block this, now at least you should know what is the answer. Isoprenaline, digoxin, mirabegron, potassium chloride. भाई कम से कम अब तो आंसर बता दो. What is the answer now? At least what is A, B, C or D? Yes, so sodium potassium ADPase receptor. This can be blocked by which drug? It can be blocked by digoxin, right? So answer is B, digoxin, guys. Answer is B, digoxin. Moving on, next question. All of the following are uses of prazosin except. So in other words, I'm asking which of the following is not a use of prazosin? Scorpion bite, hypertension, nightmares associated with PTSD or post-traumatic stress disorder, and D is insomnia. So which of the following is not a use of prazosin? So I've included some options where you know the answer. So again, you can rule out. Two options you can rule out easily. Increased insulin is yes, another mechanism. Tucker-Bursell, we know that, right? So what is the answer here? A, B, C, D. All right, so let us rule out. Scorpion bite is a use of prazosin. All of you know this. Hypertension is a use. All of you know this. So all of you know that in your exams, a lot of MCQs you'll be stuck between two options, as it is in this case, C or D. C or D. Now, when you are stuck, you don't know, try to compare these two options to the MCQ, to the drug, and try to find whichever is the best possible answer, guys. Excellent. So answer is D, insomnia. Insomnia is not a use of prazosin. Insomnia is a side effect of prazosin. So nightmares which are seen in PTSD, it is probably because what is thought is because of excess cholinergic activity leads to alpha-1 stimulation in the brain, and that causes nightmares. That is the hypothesis. So prazosin can be used. So this is not a typical use, it's an atypical use of prazosin. All right. All of the following beta blocker can lower BP in a hyporeninemic patient except. All of the following beta blocker can lower blood pressure in hyporeninemic patient except metoprolol, nebivolol, carvedilol, and labetalol. Right. So which one is it, guys? Is it A, B, C, or D? It's a very simple MCQ. If you think about the relation of beta 1 receptor and renin. Think about this. If I'm giving beta blocker to a patient of anxiety, will it decrease BP in that patient? A patient of anxiety, right? His BP is normal. It's just an anxiety. I'm giving a beta blocker. Will that beta blocker decrease blood pressure in that patient? No, because how beta blockers decrease blood pressure? Whenever you block beta receptors, you block beta 1 receptors in kidney, GG cells, that decreases renin, and that decreases blood pressure. So if there is a patient who has normal renin, in that case, beta blocker will not decrease BP. So beta blocker will decrease BP only only if renin is high. In other words, what have we studied in CVS? Beta blockers are used in young age hypertension, young onset hypertension, because it act only by decreasing renin. So in a hyporeninemic patient, beta blockers will not decrease BP until and unless that beta blocker is also a vasodilator. Until and unless the beta blocker is also a vasodilator. So now tell me, what is the answer? Accept. So the MCQ now comes down to this point: which of the following is a beta blocker but not a vasodilator? See, you guys, why do you forget about accept? This is not the MCQ that I've asked in other sessions in my channel, right? I've changed the MCQ, so I don't repeat, I always change the MCQ. So those who are answering labetalol, you have half knowledge. Labetalol is an alpha blocker. Labetalol is an alpha blocker. Carvedilol is also an alpha blocker plus calcium channel blocker. Nebivolol increases nitric oxide. So these are all third generation beta blockers which are vasodilators. So answer is metoprolol. Answer is metoprolol, guys. The MCQ is asking indirectly, the MCQ is asking which is not a third generation beta blocker. If I can simplify this down to that much, I can say which of the following is not a third generation beta blocker. You got my point? You got my point, right? So what is the answer here? A is metoprolol. It's a second generation beta blocker. The first and second generation beta blockers, they do not have vasodilatory activity. And that is the reason why, I mean, labetalol is so commonly used nowadays for treatment of, like for example, you use in pregnancy. Do you remember? In pregnancy, I use labetalol for treatment of hypertension. But pregnancy hypertension is not dependent upon renin. Rather, in pregnancy, plasma volume is high, so renin decreases. All right. Anyway, see, you have to do wrong here. Like you have to do wrong here so that you don't do wrong in the exam, right? Well, guys, the last MCQ for today: a beta blocker was given to a patient of atrial fibrillation for rate control in emergency because it is shortest acting. Which of the following drug was given to the patient? Anyways, just think, what is the answer? What is the answer, guys? Video will come back. Don't worry, guys. All right. Esmolol, nebivolol, landiolol, bioprolol, it is bisoprolol, right? All right, guys, ladies and gentlemen, the last MCQ and the last answer you have to give today. What is the answer? Now, those who have answered esmolol, that means you are not following my updates on Instagram. Currently, esmolol will not be the right answer. It is not the shortest acting beta blocker as of now. It has changed to landiolol. So esmolol has changed. So please change it in your notes. I have posted on Instagram as well, right? So landiolol currently is the shortest acting beta blocker. It has a half-life of around 4 minutes. Esmolol has a half-life of 8 to 9 minutes, right? Excellent, guys. So exporting and all of those guys who were following the updates. So it's an MCQ that I have asked on a new drug. Landiolol has been recently approved, and so thus, all right, landiolol becomes your answer here. So please add this to your notes. So the aim of these sessions is to ask you some new MCQs to make you guys understand about something, and then to update you as well, right? So that's all I had to ask you guys in today's session, guys. That's all from my side, and today on YouTube and Instagram, I'll post the schedule for next 1 week. And sometimes on Sundays, I'm out for class somewhere. Like next week, I'll be going to Hyderabad, I think. So if 1 week I cannot do the session, then I'll combine 2 weeks and I'll do in one session as we did today, right? Revision series, see, revision series, I have already given the revision videos in Marrow. So, I mean, there is no point in giving different sessions for the same things. The live session, the aim here is to keep you guys, engaged by studying pharma every day 2 hours. That's the main aim that I have, right? So, from where can we get PYTs from FMG exam, guys? Whatever notes you have, see, we teacher, what we do, we are not gods, right? Whatever notes teachers they give you, they are based upon PYTs, right? So notes are nothing but the notes are PYTs. Thank you guys. If you like the session, then Noshba Chaudhary, if you don't use Insta, then okay, you don't use Insta. Okay, so I'll put the updates on YouTube as well. I'll start putting the updates on YouTube as well. And metoprolol is not a third generation beta blocker. Metoprolol is a second generation beta blocker. Prachi Gupta, I wish I could keep the session at 9 p.m., but I don't keep the session at 9 p.m. because I have a very young daughter who is 1 year old, and I have to put her to sleep, around 9:30. That's my job, and that is what we agreed when I got married. So it is one of my job to get let her sleep, right? Lullabies and all. So 9 p.m. I cannot do that for that reason. Once she grows up, might be for a juniors, I'll be doing it 9 o'clock. All right. So about nephrotic syndrome and albumin. See, nephrotic syndrome, what happens is in nephrotic syndrome, so if you look at albumin, albumin decreases. Albumin decreases in liver cirrhosis as well, in nephrotic syndrome and CKD as well, right? In all these diseases. But in cirrhosis, albumin decreases is because of a decreased production of albumin. Whereas nephrotic syndrome CKD, it decreases because of increased excretion, right? Increased excretion. You have to understand this basic difference. And because there is decreased production, decreased albumin, that is the reason why any drug that binds to albumin, there would be a higher risk of toxicity in case of liver cirrhosis because albumin is less. Now, you'd argue then, sir, why there would be failure of drug in case of nephrotic syndrome or CKD? Because here, not only albumin is moving out of the drug, not only albumin is moving out of the body, even the drug bound to albumin is also moving out. So all in all, the total amount of drug in plasma will decrease, right, guys? All right, guys. So that's all for today, and I wish all of you guys all the best for the next week. And our next week target is CVS, cardiovascular system, and we are done with G Pharma and ANS. And if you are doing it properly, the way I have said, 2 hours today you read, 20 minutes tomorrow we revise that topic. Next day we overlook the same topic for 10 minutes. If you're doing this, now you'll realize the difference, because by the end of May, we'll be done with pharma with minimal effort, right? Just 2 hours a day, 2.5 hours a day. But the best part would be you'll remember pharma in the exam, and your efficacy would be around 99%. That is what our aim is in weekly pharma, guys. So I'll see you guys next Sunday, and take care all of you. Lots of love and blessings, guys.